Deciding how to treat patients with heart blockage has not always been clear-cut. Now, new treatment guidelines have been established to help clarify exactly what treatment should be given and when. Joining us now via satellite from Durham, North Carolina, is one of the experts who helped develop the new guidelines, Dr. Manish Patel from Duke University and the Duke Clinical Research Institute. Dr. Patel, welcome to our show.
Thanks for having me.
First of all, would you tell us about the new guidelines? What exactly do they spell out?
Their appropriateness criteria and what they spell out for patients, clinicians, and payers are times when it might be considered reasonable to perform coronary revascularization. When is it reasonable to get more blood flow to a patient's heart? And it may strike someone initially that it's always reasonable, but there's, as you know, attendant risks with any revascularization procedure. So these criteria kind of outline when it's a reasonable idea to try to improve the blood flow to patients' hearts in hopes of making them feel better or live longer.
Well, why was there a need for these guidelines? Were people being treated incorrectly? Was there a gray area there?
As you know, we have a fair bit of evidence in cardiovascular medicine, but even with evidence, when you're caring for patients, it's not always clear-cut. As you imagine, in clinics, there are patients that may represent prototypes that weren't in the clinical trials. And in real-world medicine, we're often faced with decisions where we try to do our best. In doing that, I think there is variation around the country, and whenever there's variation in what the revascularization rates are, people wonder if there's misuse, underuse, or overuse. And in response to some of those things, we wanted to provide a little bit more guidance.
Is this the case of medical therapy versus surgical intervention?
Yeah, so let me say that I think all patients should be getting medical therapy. This may be a case of getting medical therapy and then requiring more, whether it be percutaneous angioplasty or surgical intervention. So, for instance, when I see a patient in clinic and they're complaining of pain in their chest, the first issue is, do they have coronary obstruction or not enough blood flow going to their heart? If we determine that, then the question is, can we help them feel better and live just as long a life with medicines? There is a point where we feel like we can do more, and that's when we do angioplasty or surgery.
So is the intent to speed up treatment for these patients?
I think the intent is both to speed up treatment, but to allow a discourse between physicians and patients. What we've learned is that informed decision-making by patients may be the best reason to have variation in care around the country, and our hope is that these criteria will help physicians practice in maybe a more uniform way and let the patients decide their course.
Okay, and these guidelines are also for health insurers too, is that correct?
Absolutely. As you can imagine, whenever there's a variation in care, insurers or payers wonder what's the appropriate care and what should we be paying for. Often these decisions are made without physician input, and so the American College of Cardiology, the Society of Thoracic Surgeons, the Society for Coronary Angiography and Intervention, we all had representation and played a role in this document so that hopefully patients and physicians can help make these decisions. And
how ultimately will these guidelines help patients?
I think the two ways they'll help patients, first of all, is that we're going to measure our own care so that the American College of Cardiology National Cath Data Registry will put these data elements into routine care so that patients getting cardiac cath and these procedures around the country will be able to monitor care. I don't think any one physician is going to be doing what we call appropriate procedures 100% of the time, because there's always mitigating circumstances around patients that are older, have other beliefs or wishes, other comorbidities. But what will happen is that I'll be able to measure my own practice of interventional cardiology with my colleagues and see what my care patterns are and hopefully improve them. Additionally, patients will have things they can look at both online and through our own guidance to have the discussion with me and to say, for instance, I fit into this category, Dr. Patel. Why should I or should I not get more blood flow to my heart?
Dr. Patel, thank you so very much for being here.
When you think health, think IRU.